Various surgical techniques have been described for a scleral fixated IOL since its time of inception. It has moved on from suture to sutureless techniques in the 2000s. In 2018, we described about a surgical technique which not only made procedure sutureless or glueless, but also made it more anterior segment surgeon friendly with less time and resource demands.
Our technique requires the very basic of the items, and in the following video we're going to demonstrate how to perform an SF file using them. After the regularly formed 2x2mm peritomy at the 3 and 9 o'clock, the scleral surface is lightly cauterized and labeled. This is when our first custom instrument comes into play. We use the needle which comes along with a 10 ml syringe, which is approximately of 20 gauge. We call it the HTM, or the haptic tunnel maker. This needle is then bent 60 to 70 degrees at its hub with the bevel end up. This has the advantage that this angulation not just only helps on the maneuver, but also makes the procedure safe, as the needle travels tangentially along the scleral plane than in the angulation, hence preventing a full thickness penetration. This is a regular angled McPherson forceps with a 0.4mm tip. With its tips closed, it fits perfectly inside the bore of the 20 gauge needle. We use this as an advantage as we know that the tunnel that we are making will be larger than the closed tips of this McPherson forceps, hence allowing it to easily enter and withdraw from the tunnel. This leverage allows us to easily tuck in the haptics of the lens inside the tunnel, which we will be demonstrating later in the video.
Now this is the second custom instrument that we have created to guide the haptic and externalize it. The first thing that you will need is an IV line tube where you cut a 3mm segment out of it and convert it into a small square shaped pieces. You then take a 27 gauge needle, which usually comes up with a 1 ml syringe, and load the piece created from the IV line into the 27 gauge needle. The 27 gauge needle is again bent at an angle of 50 to 60 degrees near its hub. The basis is that the cut piece can be transferred into the haptic of the lens and hence acts as a haptic lock to prevent it from slipping into the vitreous cavity during the surgery. Now this angled 27 gauge needle with the haptic lock is introduced into the vitreous cavity just distal to the scleral pocket created. A simple visco cannula is used to guide the tip of the needle to the external environment. This prevents injury to the iris tissues and also to the corneal endothelium. From here on, as previously described, the haptic of the 3-piece lens is loaded into the 27 gauge needle and slowly externalized. Also notice the haptic locks come into action as the needle is withdrawn. The same procedure is again repeated on the other side. And now that both the haptics are externalized, haptic locks are removed, and with the use of the McPherson, haptics are grasped and introduced into the haptic tunnels, and the surgery is completed. Now the reason why we want to promote this technique is that it has a great potential to lead and grow. It is easy and is beginner friendly. Surgeons early in their career can be trained. On top of that, this technique also improves on existing techniques with lesser complications such as haptic exposures. In 2018, we reported these outcomes and the safety profile of this surgery in 92 patients. We found out that this surgery was even safe for this complicated cases. And in fact, it is already a recognized innovation in a developing country where this technique was awarded as one of the top 3 innovations. We need to focus on investments aimed at training or skill transfer, and also research on multi-center collaborative study to learn about long-term outcomes, safety, and complications of this surgical technique.